Hi there, my name is Nino Mihatov. I'm one of the General Cardiology Fellows. Welcome to the MGH CCU Introductory Lecture Series. Today I thought I'd talk about my framework for approaching acute mechanical circulatory support. We often think about acute MCS in the context of a patient with progressively worsening cardiogenic shock. And for the purposes of today's discussion, it's acute cardiogenic shock, as manifested by either increasing pressure or ionotrope dependence. When we think about MCS support devices, predominantly as bridges, and they can serve as a bridge to myocardial recovery or as a bridge towards a destination. And options for destination include palliation, transplant, or more durable MCS. And by that I mean a VAD, or ventricular assist device. At MGH, we have three different types of support devices we use predominantly. The first is an intra-aortic balloon pump. The second is an Impella. The third is VA ECMO. And in this introductory video, we're going to talk about each of these three devices within the context of the cardiac output support they provide, their mechanism of action, and the ventricle they support. That's RV, LV, or both. We'll start off by looking at an intra-aortic balloon pump. An intra-aortic balloon pump provides about 1 liter per minute of added cardiac output. It works predominantly by the principle of counterpulsation, and so it inflates during diastole, improving coronary perfusion, and it deflates in systole, decreasing SVR and myocardial demand. And it's predominantly an LV support device. When we look at Impellas, we can break Impellas into 4 types of Impellas. An Impella 2.5, which provides about 2.5 liters of flow per minute. An Impella CP, which provides about 4 liters of flow per minute. An Impella 5.0 provides 5 liters of flow per minute. And an Impella RP, which provides about 4 or more liters of flow per minute. All the Impellas work on the principle of Archimedes' screw, in which they take blood out of either the LV and expel it into the ascending aorta, or in the case of the Impella RP, out of the RV and expel it into the pulmonary artery. The balloon pump and the Impella 2.5 and CP and the RP can be placed in the cardiac cath lab. The Impella 5.0, however, requires placement in the OR. And lastly, we have VA ECMO. VA ECMO can provide up to 7 liters of cardiac output, therefore complete cardiovascular support. And it works essentially as an external form of cardiopulmonary bypass, in which blood is removed from the venous side of the body, passed through an external oxygenator, and then delivered completely oxygenated to the arterial side of the body. It therefore is essentially able to provide RV and LV support. And so that's a brief overview of the 3 different types of MCS used at MGH. And now I'd like to just quickly create a broad strokes framework for deciding on a device. The first question I ask is, how severe is the cardiogenic component of the shock? And I emphasize both severity and the cardiogenic etiology for the shock. If it is extremely severe, then an intra-aortic balloon pump, which only delivers about 1 liter of flow per minute, is probably not the optimal device. And the other important element in discerning a patient's clinical presentation is the likelihood that the predominant contributor to their shock is cardiogenic. These support devices work by replacing or augmenting the function of the heart, and therefore if the patient is in distributive shock, they may actually do the patient a disservice. But if we assume the patient is in severe cardiogenic shock, the next question I ask myself is their appropriateness for MCS. With that question, I'm asking several things. The first is, what are we using acute MCS as a bridge to? Do we expect myocardial recovery? Do we expect them to be a potentially transplant or durable MCS candidate? Or are we using it as to buy time as we bridge to a decision that could include palliation? I'm also asking myself, what is their candidacy for each of these particular devices and their relative contraindications, each of which we'll discuss at a later time. And lastly, I ask myself, do they have LV, RV, or BiV failure? And if it is predominantly an LV process, then a balloon pump is an option, and most of the Impellas are an option. If it is only an RV process, we can consider an Impella RP. And if it's a biventricular process, then it's almost always via ECMO. And more recently, we've started considering the placement of both an RP Impella and a left-sided support Impella. And so I'll stop there and just say this is my general framework for approaching a patient in acute cardiogenic shock for whom I begin to consider advanced therapies, what the advanced therapy options are at MGH, which are a balloon pump, Impella, and ECMO. I think about the severity of the shock and the amount of support each of those devices can provide. I then think about the appropriateness of MCS in this particular patient. And lastly, I review their echo and say, is this RV, LV, or biventricular support in choosing the optimal therapy? Thank you for joining me. Hopefully that was helpful.